And when you start cutting corners on the little things, you're eventually going to start cutting corners on the big things, and that could be detrimental to a patient. Very, very set on the fact that integrity is a big part of what we do.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement, because we all know emergency nurses have the best stories. Now here's your host, Kevin McFarland.
Hey everybody, Kevin McFarland here, and welcome back to the Art of Emergency Nursing. Thanks for listening to the podcast. Just a reminder, make sure that you are sharing these episodes with your friends, your family, your peers, people you like, people you don't like. Everybody needs to hear this podcast. My guest today is an ER nurse educator, and an ER nurse leader. He's going to share a little bit about his background, his experience, and a little bit of his wisdom as a nurse mentor and leader as well. You are going to love this episode with my friend, Jack Rodgers. Introduce yourself, tell the audience who you are, what you do.
My name's Jack Rodgers. I am currently working as the interim director of emergency services for a smaller hospital system in the Columbus, Georgia area. Have a varied background that takes me pre-nursing into a realm that some people kind of scratch their head when they say, "You did what?" And that would be TV sports broadcasting for almost 20 years.
Holy cow.
Prior to making the decision before I knew I needed to grow up and get a real job. And, nursing was something that came up that seemed to be a good fit because of some other life experience along the way. And, have moved up through the ranks, starting off as that new grad, nervous as all get out, hitting the floor for the first time, to charge nurse, to unit educator, to managerial type of roles, and a little bit of everything in between.
Nice. Now, how does one go from sports journalist to nursing? How does that happen?
Well, like I said, you have to realize there's a time when you have to grow up and get a real job. Not that the TV part wasn't a real job, but I started that right out of high school.
No kidding.
Won't bore you with the details of the pieces that fell into place, but it was one of those. I never had a degree for that, never formally trained. It was hey, if you've got any kind of interest in working here, we can show you the ropes. And that little entry level position went from place to place to place to place inside one building that landed me in the news department, first taking pictures and then doing little short news cut-ins early in the morning before there were ever hour-long and 2-hour-long local newscasts early on. And from there to a sports job. I think they were excited about the fact that they had a hometown guy that was able to do that kind of stuff and knew the area, so they gave me a shot at it, and it worked out pretty well, and did for quite a while. Got to the point to where my kids were grown enough to start thinking about, oh my gosh, one of them's going into high school, the other one's going into middle school, and we lived at different ends of the clock. They got up early in the morning, went to school, did their thing. I rolled out of bed about noon, into the shower and out in time to get in the car and be at work between 1 and 1:30 to work until well after the 11 o'clock news. Come home, everybody's asleep. So we literally had a lot of weeks during that entire time frame where I may have seen my kids once during the week, and realized that things needed to change if I wanted to spend some quality time with them before they grew up and moved off and started doing things on their own. The piece that kind of connects the puzzle is there was a little sabbatical from TV for a little while in the middle of all that in the early 90s, where a friend of mine who worked with the local fire department was an EMT instructor, and he had been trying to get me to take his class for a long time. And the pieces just finally fell into place. I took that class and loved it. Pursued, even when I went back into TV, pursued getting into programs to get my paramedic certification completed. And literally there was a time when nursing school was going on, and then graduation into a nursing role full time, that I was doing the TV, the paramedic stuff, and the nursing all at the same time.
Wow. Holy
And
cow.
people would look at me kind of cross-eyed and say, "You're doing what?" But that's just the way my path kind of led, and thank God it did. I think I'm in a place now where, in the TV business, if you do a good job, you get a little trophy to prop up on on your shelf, and a little plaque to hang on the wall. Whereas you do a good job in what you do clinically at work, somebody may have a chance to go back home and spend time with their family where they may not have to begin with. So it put a fresh perspective on things for me.
Good for you. That's now the question I have for you, like, you had to have been recognized when you started working as a nurse. You had to have been recognized from being on TV so long.
Dude, one of the funniest stories that I can remember was actually when I was on the truck riding the call as a medic. We went into a little neighborhood locally where I forget the nature of the call. Somebody was sick, didn't feel well, something like that. It really wasn't anything significant. But we walked in and standing there talking to the elderly lady that was there, and she had a family member sitting there that every time I turned around and looked, they just stared at me, and I couldn't figure out what was going on until it finally clicked. And we walked outside, and I told them I was going out to get the clipboard so we can get some paperwork signed and all that. And said, "You look a lot like that man on TV." I said, "Which man is that? Which one are you talking about?" And he started spouting some names, and said, "Well, okay, well, I'm flattered that you would think that, and strung him along a little bit." And then we went back inside, got the paperwork signed. Turned out the patient didn't want to go to the hospital with us, so we got our paperwork done and started to walk back to the truck. And I conveniently let one of my TV station business cards fall out of my pocket. And by the time I climbed up in the truck and looked back out the window, he had picked it up and looked at it. And this big grin on his face, he started jumping up and down. "I knew it was you. I knew it was you."
That's funny. Holy cow. You're like, "Hey, wait, usually you're on my TV. What are you doing here in my living room?"
And it's funny too. The place that I live is referred to as one of the small city with a really small town feel to it. Everybody knows everybody or is related to somebody. And I still and I've been out of TV now for good for about 13 years. And I still have people when I run across them in the ED, "You look so familiar. Where do I know you from?" And my response is, "Well, what have I ever done to you?"
Yeah.
We must have crossed paths at some point in the past. But I never come right out and say, because I don't want it to seem like I'm bragging or boasting or just kind of play along with it, and the conversation turns back to them, and we go on about the business of taking care of them.
Yeah. And what's happening is, 2 or 3 days later, they're going, "Holy crap, that was Jack Rodgers."
Yeah. Every now and then you'll find somebody who still remembers the name and the face. It's like, wow, you truly do not have dementia, do you? That's a great memory.
That's pretty funny. So a long time ago, I was in one of the episodes of Trauma Life in the ER.
Yeah.
And I was teaching EMS at the time. One of my students goes, "It's the weirdest thing." He goes, "I was watching TV." He goes, "All of a sudden I look up and there's Kevin on TV." He's like, "Holy kids." He goes like, "Wait, that's my instructor. Hold on."
No, I know, right? And you get stuff like that just because of the nature of that business. My kids grew up watching me on TV.
That's kind of cool.
Their friends would always say, "Oh, wow, your dad's on TV," and yeah, whatever, big deal. But we also knew that because of the way this town is and has been historically, that we could always tell them, "Don't do anything because we'll find out about it." And
it's true.
You see people out in public and you'll talk to them and call them by name, and they'll look at me and it's like, "Man, you know everybody, don't you?" And I tell them, "No, I don't. I never profess to know everybody there is, but the ones that I don't, your mother does." So we're covered either way.
You're like, "So yeah, we're keeping an eye." So
yeah,
that's awesome. So how long have you been a nurse?
I graduated from nursing school with my BSN in 2005. So it'll be 15 years this year in May.
Me too. So, holy cow. And At what point in your nursing career were you sure that you made the right choice?
I was sure I made the right choice when I started. Because of my experience as a medic on the truck, all I ever knew was the ED environment. It fascinated me as a medic walking in, and just in the short length of time that I had a patient in the back of the truck, and then watching the transition of care from that environment into the ED. And as we would stand around and finish our paperwork and trip reports and that kind of thing, watching the nurses interact with the patients and the scurrying about and the paying attention to detail, even in the midst of chaos. I thought that was really kind of cool. And just kind of fell in love with it. I don't think, even though I had multiple offers coming out of school to go into ICU, OR, things like that, I never really considered them. My heart had always kind of pulled me to the ED, and I don't think it's swayed one way or the other since I started.
That's kind of cool. So, tell me about a patient that changed the way you practice.
Oh, wow. Get your tissues out. This one's going to hurt a little bit. It's been several years. Hospital I was working at the time had gone for about 30 years without having any OB services. They had it way back when, shut it down for whatever reason, and then went for a long time without. Through some hospital expansion projects and creating more room and wanting to boost their service lines, they opted to bring OB back in at a point several years ago. And you know how that is when a new department, new service line, that kind of thing opens up. It's tough to get to know people who are associated with that, because they may come through once just to say, hey, we're who we are, and then they disappear and you don't see them again. So it's hard to learn who they are and put names with faces and that kind of thing. We had run a few drills. Oh, what happens if pregnant mom comes in? She's laboring, contracting. What's our process going to be to get them from the ED to L&D and get things started and that kind of thing. So we worked through that and went through all that ubiquitous kind of minutia that goes along with setting up processes and that kind of thing. But it was literally just a few months after OB opened, and we still didn't know that staff that well, that we got a phone call with a heads up that there was a pregnant mother who was probably in the 28 to 32, 33 week range in cardiac arrest.
Oh.
And we kind of took a breath and figured, okay, where are our resources? And one of the things that OB had always taught us, if you ever have a question about anything, here's the number to call. And we had that number placed at every phone in big font right above it. So if there was ever an issue, we wouldn't have to go scrambling to find a number. So we made that phone call and told them what we had heard. And within minutes, there was a full OB team up there with all the baby stuff they needed. They brought with them, grabbed one of their OBGYN docs and kind of pulled her along for the ride. And we happened to just worked out that we had one of our critical care bays that had 2 empty beds in there separated by curtain. So we chose sides. ED staff on one side, getting ready for mom to come in, OB staff on the other side, ready to take baby when we get baby out. And when mom rolled in, literally, it was less than 3 minutes by the time mom hit the bed and baby was out. Compression still going on and all of that. We continue to work on our side, and we're listening pretty intently to the other side to hear what was going on. We finally heard somebody on the other side said they'd gotten a pulse back on the baby, and they disappeared. They shot down into their environment to do what they needed to.
Yeah.
Long story short, not a good outcome on either end. And it made us kind of think, first of all, it's like we got kicked in the gut.
Yeah.
to go through that with the anticipation that we're going to do our best to make a difference. And, we struck out on both accounts. And to see the staff kind of suffer through that, everybody's got critical incident debriefing policies and practices and the way they do that, but we're just what I think is like almost every other ED is like. You just a lot of times learn to deal with it. Go outside, cry for a minute, come back in, and get back to work. And most of the time that works, but this time it didn't. You could tell the staff, top to bottom, front to back, was just shaking. So that's the first time. That's actually the only time that I can think of in 15 years of ED nursing where we made arrangements to have staff from upstairs come down and do some of the task work to take care of our ED patients, so we could pull the ED staff in and do some debriefing and counseling. We got our chaplain services involved, and that was the day where I realized all of the talk about taking care of yourself, taking care of your staff really kind of hit home. I'll admit to you, I'm one of those kind of guys who have that twisted ER sense of humor. We laugh about it as a way to deal with it, that kind of thing. But, I'd be lying to you if I told you that it didn't bother me as well. And, we all learned a very valuable lesson about taking care of ourselves and each other in the face of situations like that.
Yeah. It's, when you have cases like that, boy, it can rock the staff. And they may not even realize it, but it hurts.
Yeah, it does. And you wonder, you know that there are those crusty old ones that get in there from time to time that, regardless of what happens, they can shake that off. But you worry specifically about those that are newer, that have never experienced something like this. Even to the new grads who've never seen a code with a death involved, that haven't really learned that process of, okay, how do we handle this? How do we deal with it? How do we transition? How do we still get the work done? And then how do we move on from there? And to think that maybe you had somebody in a role like that where they've never seen that, and now this is the first episode of that. It's like, wow, you just got sucker punched. Are you going to be able to rebound from this? So, we made it a habit from that point going forward, to where anytime we saw signs in any of our staff members that they weren't handling something well, we got one of our chaplains involved and got them to come down and to do some one-on-one with them. I don't think or at least I don't remember any other situations where we pulled a group away like we did in that circumstance. But we at least made some one-on-one personal time available for those folks to be able to deal with it.
Good for you. We had a real similar situation with a 8-month pregnant GSW to the chest, and I'll never forget, because I was working part-time at the hospital and I was working part-time at the community college teaching EMS, and we had one of our paramedic students. It was his very first clinical shift, and he ran that call.
Yeah.
And we were like, holy cow. And he was trying to give a report as quick as he can and try to get out of the room and try to get out of the way.
Right.
And as he was kind of hightailing it out of the room, I grabbed him by the collar and I was like, nope, get in here and watch, and see the fruits of your labor. And sure enough, they did a crash C-section, got the baby out quite quickly. And of course, mom was not to be saved.
Right.
But by golly, that medic and his hard work, they saved that child. And
that I think a lot of times, if it works right, and individuals are different, I get that, but sometimes it takes something like that to really make a nurse think, that question you asked me, how do I know I'm in the right place? What was it that proved that to me? And that may be the situation where you finally see somebody who struggled a little bit actually step up and say, let's get it done.
Let's do this. Yeah, absolutely.
I look back to my time as a paramedic, transitioning from that new medic into a role of now crew leader, where you're the one responsible for everything on that truck, regardless of who's taking your patient. And I remember the day they put me in charge for the first time. We were coming into the station to put an odd-houred shift truck into service, and had just finished checking that truck off to make sure things were there when we got a phone call, or one of the ambulances from across town, because we were not in service yet. One of the ambulances across town were dispatched into our territory on a shooting. And what they did was they said, this truck, which is mine, they were referring to, this truck is going into service now. Go ahead and let them take the call. And about the time I heard that, my phone rings and I answer, and it's our assistant chief. He said, "You got this. Congratulations, you're a crew leader. Get it done." And obviously, I whistled a couple of tunes because of the pucker factor on the way there. But when you got into the situation, you fall back on what you learned, because in every aspect of what I've done from a training standpoint, whether it's medic, nurse, whatever, I learn, and then I try to practice, and I try to practice, and I try to practice, because the more you practice, if you practice the right way, that practice is going to make itself evident in the way you perform when it's time to get it done.
Tell me about the first time you made a medication error. Do you remember that?
Yeah, I do. Absolutely. Got a patient that's got some cardiac issues, came in feeling a little flustered, couldn't catch her breath very well, palpitations and all that good stuff. Watched them struggle a little bit until they started to Brady down just a little bit. And the doc at that point said, too low. Let's do something to get that heart rate back up. So they ordered some atropine, and this is back when atropine was used a lot more widely than it is under the new guidelines. But they grabbed some atropine. Let's get a little atropine on board, see if they get their heart rate up a little bit. And I was the dude that was running the crash cart and grabbing the meds and getting all that done. And all I did was look down and saw the vial with the A on it. I drew that up. We skeeted that in, and I looked down and it said adenosine and not atropine. Yeah, no kidding. Man, my eyes went to that monitor and prayed, please God, please God, please God, don't let it go away. And, that's such a short-acting drug. You saw another little dip that made me gasp just a bit, but then, everything went back to the way it was. But the tough part about that was it wasn't admitting to my boss or the staff around that I goofed up. It was going back to that patient after the fact and said, look, I just want to let you know I made a mistake. And they were very appreciative of the fact that, I was so forthcoming with that, because, I know the temptation is there to say, ooh, nobody saw that. Who's going to know? If nothing bad happens, whew, I dodged a bullet. But I'm not like that. I'll own up to it if I did it, or if I didn't do it, if that were the case. And, I want to make sure that everybody knows everything. It's like I heard recently, I don't like Easter eggs. And when I asked what that meant, you hide all the eggs on Easter, you go looking for them, and then about 3 months later, when you come out to cut that grass, you realize there's a couple of eggs left over, and when you open those up, they don't smell so good anymore, right? I don't like surprises like that. So, I've kind of adopted that same mentality. I don't like the surprises either. I want to be upfront and honest, and would expect that anybody else in a similar situation would be that way with me should something happen. And but boy, I tell you, I was a lot more careful, especially in code situations, to look and see what was in my hand before I started jamming needles in it to draw it up.
It's crazy how you got to look again, check one more time. Make sure you know what you're doing. So
yeah, no kidding.
But it gets a little scary.
Yeah, no, you're right.
It gets a little scary, that's for sure. So, as long as you've been a nurse and you made the transition from EMS to nursing, what do you think are the advantages and disadvantages of coming from an EMS background to nursing?
I think the disadvantage, at least into getting into nursing and getting started, is you go from a situation where you're fairly autonomous, working off of protocols with nobody looking over your shoulder, knowing that you got some guidelines to do the right thing, but you're the dude. I mean, you're the one that's got to get it done. And you kind of get, I don't want to say a cockiness, but a confidence that goes along with being able to make those decisions, which protocol we need to use. And, in my case, what pieces of that protocol were applicable to this patient and making sure I do the right thing for that right patient. That was a little difficult for me transitioning from the field into the hospital, because I guarantee you, I'm just like that giddy little teenage coming out of college with their nursing license for the first time. On that first day that I took a team of 4 all by myself, I was sick to my stomach and questioning every move that I made the entire shift. It's a different mindset. We've talked about that before, about how mindset comes along with practice and the way you're trained and the environment that you're in. That was just it. I think the good part about the transition is I know what the front end is like. A lot of the staff in the ED does not know what that patient went through and what those medics had to go through to take care of that patient and get them not just to the ED, but to the ED in the condition that they're in, without knowing what they look like to begin with. I'll give you a great story. I had a patient that when the tones went off, all they dispatched us to was what they called an industrial accident. Now, this is back in a time where industrial accident could have meant they were at work and they slammed their finger in the car door getting ready to go home, or, just silly little stuff like that. So we hopped in the truck and we start heading across town. And 5 minutes into the ride there, the first fire truck on the scene gets on the radio and starts screaming, "What's your ETA? We need you now. We need you now." We kind of figured, well, there's probably a little more to it than the finger. So we walk in and it's a machine shop where a guy was trying to reload a spring of some kind under pressure, had it on a big press, and the spring popped off the press under about 5,000 pounds per square inch of pressure. And it basically took the right side of his head off.
Holy cow.
We are led into the shop, which is a nasty, you really don't want to work medical type of stuff in an environment like this, but we get there and lo and behold, the patient is still breathing on his own. He still has a pulse. It's like, okay, we got to do what we got to do.
Yep.
So I'm on my belly on a greasy shop floor trying to get the guy's airway clear and intubated, while my partner is, trying to slam an IV in to get some fluid started, while the fire guys are getting a stretcher and getting everything ready for us to get this guy up and out. Obviously with a wound like that, it's not survivable, but with the efforts that we did, the guy still had a pulse and was still breathing on his own when we got him to the hospital. So to be able to see what a patient goes through in a circumstance like that, that's a gift, I think, a lot of times, because it makes you think, what could have been going on out there? Why did the medics do these things or not do this and this and this when they brought our patient in? You got to think back to, well, did the situation warrant at the time? Did something change? Or were they physically able or limited in any kind of capacity from doing that just because of the environment they had to work in?
Absolutely.
And nurses don't get it sometimes when you tell them. I remember a call where I walked in to talk to a lady who said she didn't feel good, and I had to march in place. I couldn't stand still and couldn't sit my stuff down, because if I stood still long enough, the roaches would run up my pants legs.
Oh, Lord.
They don't get that. They don't understand the environment. They have only worked in controlled situations, controlled environments of the hospital, the classroom, things like that, So I think that's a huge plus from those who start on the pre-hospital side and move into the ED. You see the big picture.
That's for sure. I mean, it's definitely, you realize there's definitely a difference in the environment makes a big difference. It's a lot different taking care of somebody at their house instead of yours. And and sometimes you can't get what you want to do done because you're just too busy just trying to keep them from crumping.
Yeah, I've seen a lot of nurses kind of giggle about the fact that when you pull your crash cart out, you spin it around, look on the back. There's that little plexiglass board you're supposed to slide up under somebody before you do compressions, and they think, "Oh, that's ridiculous. Why do you need something like that? Does it make that big of a difference?" And you tell them about the time where you walked in on a family member who's doing CPR on their grandmother, but oh, by the way, grandma's on a waterbed. How effective do you think those compressions are? So it kind of brings home the fact that we teach you these little things for a reason because it makes a difference.
Yeah, it does makes big difference. What's your best memory of being an ER nurse?
Oh, best memory. I think there's a couple of things, from a standpoint of being that bedside or stretcher side caregiver. Um, to hear that little lady who comes in after church on a Sunday morning, goes to get a little bit of dinner after church and then doesn't feel well after dinner, so the family brings them to the ER. I just don't feel good. Well, let's take a look and see what's going on. And by the time you get her spun around to sit down on the bed and check her vitals and all the other good stuff, she kind of blinks at you and says in a quiet voice, she says, "I'm going." So where are you going, honey? You just got here. It's going to be a little while. She said, "No, I'm going." And just as we get the last electrode on and that lead wire in place, her eyes flutter. We look up and she pops in the V-fib just like that.
Holy cow.
I've always been told when a patient tells you they're going to die, guess what they're going to do?
Die.
Yeah. So, the ability to, because there weren't a lot of people in the room at that point because it hadn't been a code up to that point. Just so happened she was in a room that had a crash cart right there next to her bed. And our defibrillators at the time were so old, they still had manual paddles on them. So instead of snatching everything open and trying to put this and place that and, lick, tuck, seal, lift, move, all that you're supposed to do, I grabbed the paddles, I juiced up the machine and I manually shocked her. And, I had to ask for forgiveness for the burn marks after the fact, but one pop and she sat straight up in the bed and came right back to. And she still, to this day, I run into her quite frequently. She calls me Sparky because I was the guy that gave her the shock to get things started. And, just the ability to kind of, I guess, react, or act rather, based on training, to act rather than react to the situation. Because sometimes when you just react, the right things don't always happen,
Yeah.
So that from a bedside standpoint, from the education standpoint, it's going through a class and going over maybe for the 15th time in 2 days how this works and how it applies to what you do, and finally seeing that light bulb go off over their head when they get it. That's just one of the greatest feelings to me, is to be able to pass along some knowledge what makes somebody else's practice better and see how they use that and teach others going forward.
It's a good feeling.
Yeah, it is.
Speaking of teaching and mentoring nurses, I'm sure you're in a position where you often get a chance to ask, nurses ask you for advice. What's your go-to advice for new nurses?
It would have to be, don't be afraid to ask questions. I think there is an expectation sometimes that when nurses get out of school and they pass their boards and they walk into an environment where it's time to put all of that into practice, they're expected to know everything they need to know to be successful. And that's not the case. I don't know of anybody that's ever been a nurse that walked into that department for the first time and could confidently say, "I know everything I need to know to be successful today." It doesn't happen. If they're telling you that, they're lying to you. I find that in years of watching some of the new grads, not all of them do it, but a large majority still have that mentality that, if I ask a question, they're not going to think I'm competent. They're going to think less of me for that, which, I think absolutely the opposite. If you don't ask me questions How do I know what you need to know, what you don't know, so I can help you fill those gaps and get where you need to be? I'm not a mind reader. I'm an educator. I can give you the tools and help you be successful. But I can't read your mind. So you're going to have to let me know, hey, I'm struggling here. What can you help me with? And I'm glad to step up at that point and say, hey, let's work on this. So, again, back to watching that light bulb go off when those folks finally get it. They understand.
Absolutely. What does it take to be a stellar nurse?
Integrity and consistency.
Good answer.
I think I don't think you can be a stellar nurse and not have the integrity to know that. And by integrity, I mean that thing that we've come to kind of refer to as doing the right thing even when somebody's not watching.
Yeah.
In the environment that we work in, the fast pace, the expectations of throughput measures, and all of that good stuff, there is a serious temptation to cut corners wherever you can. And when you start cutting corners on the little things, you're eventually going to start cutting corners on the big things, and that could be detrimental to a patient. So, very, very set on the fact that integrity is a big part of what we do. Yeah.
That's good advice. What's the best advice a nurse mentor ever gave you?
I think the best that comes to mind, the best that my preceptor told me early on is just relax. You get so uptight in the environment, knowing what the expectations are, especially if you're new to the field, new to the environment, new to nursing. You're expected to know a lot of stuff, and sometimes you get a little uptight about that. And a lot of times, even if you don't know everything that you need to know about everything, if you step back, take a deep breath, kind of think it through for just a minute, you can get yourself on the right track. Again, you have to be able to or be willing to ask for help when you need it. But just to back up and say, look, don't take yourself so seriously. Don't be so hard on yourself because you don't know everything you think you need to know to be successful. Take a step back, do what's right for the patient, knowing what your limitations are at that point, and then be willing to reach out to the people who can help you overcome those limitations and figure out a way around that.
Absolutely. Well, as we kind of wrap up, one of the last questions I always ask somebody is a question called 3 things. And this one's kind of a hard one.
Oh.
What are 3 things? What are 3 things an ER nurse should always remember? And what are 3 things that they can just go ahead and forget?
So the 3 things to remember, obviously the one I just mentioned, don't be afraid to ask for help. Even nurses that have been in the ED for a long time still need help from time to time, and don't be afraid to reach out. Don't think that somebody's going to think less of you because you need that. There are times where in clinical shifts that I've worked recently with this or with this or with this, and to take a step back, take a deep breath, think it through, go back in, and if I hadn't asked for help, not necessarily a bad outcome for a patient, but their experience might not have been as good. I might not have been as efficient in getting the work done that needed to be done for them as I could have been. So don't be afraid to ask for help. The next one of that would be don't be afraid to try. Like the example that you give. All right, buddy, get in there. This is your turn to see what kind of outcome comes from, those fruits of your labor. You're never going to know until you try.
Absolutely.
So, don't put the patient in a precarious situation because you're now trying something. But I think everybody has a little bit of common sense to know that, I'm not going to get good at this if I don't get in there and try and work and go from there. The other would be chase your dream. There are so many things that emergency nursing has to offer. It doesn't necessarily have to be stretcher side nursing. And as well as I do, there's research, there's education, there's outreach, there's community awareness, there's all this other stuff that falls under that heading of what we do as a profession. And there is a niche for everybody. If the ED is truly your calling, you'll find a place to fit. You'll know what that fit is for you. So if you have a dream that says, I want my career to take me down this path or down this path, don't be afraid to dream, because you'll never be able to get there if you don't take that first step.
That's good advice.
All right. As far as what to forget, forget how you documented in nursing school, because it has nothing in common whatsoever to the way you're going to document in real life. The advent of computers has been probably one of the biggest reasons for that. But I still see a lot of nursing programs who come through and their students will pull out the old blank piece of paper progress note or a nursing note, and they'll handwrite what's going on. And that's just not the way it happens. You don't have time to do that anymore in the environments that we work in and with the expectations that are leveled on us. So forget about the documentation. Get in, apply your skills, and then learn from your facility and your documentation platform the appropriate ways to be able to document on a patient using those tools. What else can you forget? Forget that you're on an island, or forget the fact that you may think you're on an island. Nobody else knows what I'm going through. There's so much stress. There's so much this and that that's getting in the way of me being able to. Trust me, that's the reason that I got involved with ENA my first year out of school, is that somebody decided to invite me to a conference and got me networking with people from all over the country who had the same problems and went through the same crap every day that I did. My problems weren't isolated to just me. So don't, forget the fact that, or don't ever think that you're on an island, because you're not. There are people out there that can help walk you through some of that stuff.
I think that's one of my favorite. I think that's one of my favorite things about emergency nursing and about getting involved in the ENA is you realize that if you go to these conferences and you spend time with other nurses, you realize that everyone's about as screwed up as you are. Like every place has their things that are good and things that are bad, and we're all still trying to kind of figure things out.
Yeah, absolutely. I think the third piece to that would be, it would be, don't forget that you have resources. You're not expected to be able to know it all and do it all. You have those you can lean on. You have educational opportunities and guides that you can learn from. You've got people to network with. You have processes in place. You have the tools available to make you who you want yourself to be. So just forget the fact that, there's no help out there for you, because there are plenty of resources and plenty of things that you can do to better yourself, to educate yourself, and to be that nurse that you can be.
Well, Jack, this has been a lot of fun, my friend. It's been a lot of fun to visit with you and kind of catch up. You're one of my favorite people to look for at the conference, and someone I'm always looking forward to seeing.
Kevin, I appreciate it, man. I'll see you soon.
Take care, man. I'll see you soon.
All right, later.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.